Postoperative fluid therapy is a critical component of surgical patient care and plays a decisive role in patient recovery. Following surgery, patients are particularly vulnerable to fluid shifts, electrolyte imbalances, and hemodynamic instability. These changes occur as a result of blood loss, tissue trauma, and the body's physiological stress response to surgery. The primary goals of postoperative fluid therapy are to maintain effective circulating volume, ensure adequate tissue perfusion, and preserve electrolyte and acid-base balance. Appropriate fluid management helps prevent serious complications such as acute kidney injury, pulmonary edema, and delayed wound healing. Nurses have a central responsibility in this process, including assessing fluid requirements, administering intravenous fluids safely, monitoring patient response, and identifying early signs of fluid imbalance. Surgery induces a complex physiological stress response designed to promote survival. This response is mediated through activation of the sympathetic nervous system, the hypothalamic pituitary adrenal axis, and inflammatory pathways. Surgical trauma leads to the release of catecholamines, cortisol, aldosterone, and antidiuretic hormone. Together, these hormones promote sodium and water retention, increase blood glucose levels, and alter vascular tone. Although initially protective, an exaggerated or prolonged stress response can contribute to fluid retention, electrolyte disturbances, impaired wound healing, and organ dysfunction in the postoperative period. Several hormones play a direct role in postoperative fluid balance. Antidiuretic hormone, or vasopressin, is released in response to stress, hypovolemia, and increased plasma osmolality. It promotes free water reabsorption by the kidneys, which can lead to dilutional hyponatremia. Aldosterone, activated through the renin-angiotensin-aldosterone system, causes sodium and water retention while increasing potassium excretion, predisposing patients to hypokalemia. Cortisol and catecholamines increase gluconeogenesis and insulin resistance, leading to stress-induced hyperglycemia, which is associated with poor surgical outcomes. Postoperative patients experience fluid losses through multiple mechanisms. Blood loss may be overt or occult, and clinical signs often appear only after significant volume depletion. Surgical drains, nasogastric tubes, chest tubes, and urinary catheters may contribute to measurable ongoing losses. Third spacing, a common phenomenon after major surgery, refers to the movement of fluid from the intravascular compartment into interstitial or serous spaces. Additionally, insensible losses increase due to fever, open wounds, and large surgical exposures. All these losses must be considered when planning postoperative fluid therapy. Third spacing occurs due to increased capillary permeability and reduced oncotic pressure, often associated with inflammation and hypoalbuminemia. During the first 48 to 72 hours after major surgery, large volumes of fluid may shift into interstitial spaces, leading to edema, ascites, or pleural effusions. Although total body fluid increases, the circulating volume may be reduced, resulting in hypovolemia. As inflammation resolves, this fluid returns to the circulation, which can precipitate fluid overload if intravenous fluids are not appropriately reduced. Careful nursing assessment is essential during this phase. Postoperative fluid therapy can be classified into resuscitation, replacement, and maintenance therapy. Resuscitation fluids are administered rapidly to restore organ perfusion in patients with hypovolemia or shock. Replacement fluids are used to compensate for ongoing losses, such as drain output or gastrointestinal suction. Maintenance fluids provide daily water, electrolytes, and minimal calories for patients who cannot tolerate oral intake. Selection of the type and volume of fluids depends on the patient's hemodynamic status, type of surgery, and underlying organ function. Crystalloid solutions are the most commonly used fluids in post-operative care. Normal saline is useful in hypovolemia, metabolic alkalosis, and head injury, but excessive use may cause hyperchloremic metabolic acidosis. Lactated Ringer solution has a more physiological electrolyte composition and is suitable for many surgical patients, though it should be used cautiously in liver dysfunction and hyperkalemia. Plasmolite is a balanced solution associated with fewer acid-base disturbances, but its higher cost limits routine use. Nurses must understand the indications and risks associated with each fluid. Colloid solutions, particularly albumin, have limited indications in post-operative patients. Although albumin can temporarily expand intravascular volume, evidence does not show a mortality benefit, and risks include pulmonary edema and increased intracranial pressure in neurologic patients. Synthetic colloids are rarely used due to renal and coagulation complications. Blood products are reserved for patients with active bleeding, symptomatic anemia, or coagulopathy. Transfusion decisions should be individualized with careful monitoring for transfusion-related complications. The primary objective of fluid resuscitation is restoration of tissue perfusion rather than normalization of blood pressure alone. Indicators for resuscitation include hypotension, tachycardia, reduced urine output, altered mental status, and elevated serum lactate. Fluid challenges are administered in small boluses, typically 250 to 1,000 milliliters, followed by reassessment. Failure to respond to fluids should prompt evaluation for ongoing bleeding, sepsis, or cardiac dysfunction rather than indiscriminate fluid administration. Once adequate perfusion is achieved, maintenance fluid therapy is initiated. The average adult requires approximately 30 milliliters per kilogram per day. Maintenance fluids may include isotonic or hypotonic saline with or without dextrose, depending on serum sodium and glucose levels. Potassium supplementation is added only after ensuring adequate urine output. Patients with cardiac, renal, or pulmonary disease require lower fluid volumes to avoid overload. Nursing judgment is crucial in adjusting maintenance rates based on clinical response. Continuous monitoring is essential in post-operative fluid management. Clinical parameters such as heart rate, blood pressure, capillary refill, and urine output provide immediate information. Laboratory investigations, including electrolytes, arterial blood gases, and serum lactate, help assess metabolic status and tissue perfusion. Advanced methods such as passive leg raising and bedside ultrasonography can guide fluid responsiveness. Central venous pressure alone is not a reliable indicator of intravascular volume. Nurses play a pivotal role in safe postoperative fluid therapy. Responsibilities include accurate intake and output recording, monitoring drain losses, timely reporting of abnormal findings, and early detection of hypovolemia or fluid overload. Nurses must ensure correct fluid administration, observe for electrolyte imbalances, and provide patient education. Effective nursing surveillance significantly reduces postoperative complications and improves surgical outcomes. Please like, share, and subscribe, and leave your questions as comments.